Good morning, everybody. My name is Augusto Federici, and I will speak today about a topic called optimizing clinical and laboratory diagnosis of von Willebrand disease. In the second slide, I would like to summarize my presentation outline. I will first talk about the role of von Willebrand factor and pathology of von Willebrand disease, classification of inherited von Willebrand disease, guidelines for clinical and laboratory evaluation, review of diagnostic methodologies, optimizing laboratory testing and patient management, and at the end, I will be pleased to answer some of the questions that this presentation will raise from the audience. I will start with, first of all, with the role of von Willebrand factor and pathology of von Willebrand disease, as shown in the title of the next slide. What about the history? The history actually comes from February 1926, when a doctor from Helsinki named Erik Adolf von Willebrand published a paper in the Finnish journal showing a very peculiar family who had many children dying for major bleeding. And the peculiar aspect of this new family was that differently from the classic hemophilia that was well known at that time, most of these young people were female. So Erik von Willebrand at the beginning immediately found out that this was a completely different disease from the classic hemophilia everybody was available. This was available at the time. This paper was very seminal, but it took more than 30 years to have more evaluation, better evaluation of the von Willebrand disease families. Once at that time, in 1955, Inga Maria Nilsson from Malmo was publishing in Acta Medical Scandinavica a very detailed description of the original family by von Willebrand. Only 12 years later, the presentation, the description by Inga Maria Nilsson, there was a very seminal paper by Ted Zimmerman, Theodore Zimmerman, who published in 1971 the first evaluation that by using specific antibody, the two diseases, inherited diseases, von Willebrand disease and hemophilia A, were completely different because a protein called later von Willebrand factor was present in patients with hemophilia A, but it was not present in those members of the family described originally by Dr. Erik von Willebrand. This is the history. Of course, later on we have more information. And nowadays we know very well that von Willebrand factor is completely different protein from factor 8 that is absent or deficient or defective in hemophilia A. What about von Willebrand factor? Von Willebrand factor is a multimeric glycoprotein of 540,000 20 million Daltons. It is synthesized by endothelial cell and megakaryocytes, and is a primary gene product, is a large gene on chromosome 12, is able to to generate a protein of 2,813 amino acids. The entire sequence of von Willebrand factor is makes a product that is from the amino terminal portion until to the carboxy terminal. And you can see from the slides that there are specific activity shown in specific domain of the protein. From the amino terminal, we have the sigma peptide, then we have the propeptide, then we have the factor VIII binding, and most interesting, the central part of the protein, A1, A2, A3 domains, contains the most important part of the von Willebrand factor activity, namely the glycoprotein 1b alpha, the collagen 7 and heparin binding sites on the A1 domain. Then we have at the A3 domain the binding for the collagen type 1 and 3, and at the side of the carboxyl terminal site, so we have the binding site for the glycoprotein 2b3a of the platelets. But the most interesting part, important part of this protein, that in order to make von Willebrand factor functional, we needed to have multimers, and dimers first and then multimers. And at the carboxy terminal side, we have two cysteine, very important, that makes dimer, and at the D3 domains, we have cysteine that are able to make the multimers. This protein can grow as much as possible, and therefore they can be so big to damage the microcirculation in order to have a microthrombi into the microvessel. But this protein is also regulated by a specific enzyme called ADAMS13 that makes a cleavage, a specific cleavage at the cleavage site between inside the A2 domain. So this protein is also cleaved into the circulation. The multimerization of von Willebrand factor is shown in this slide. You see that we have the monomer, then we have the dimer in the endoplasmic reticulum, then we have the multimerization, the glycosylation in the Golgi apparatus, and then we have the cleavage of propeptide in the viable pallidal bodies. So what about the role of multimers and the dimers? You see that the dimers are at the bottom and the multimers are at the top. The function, the activity of the von Willebrand factor, the antigenic activity is present all over, and the binding to factor VIII is contained in all the multimers, but only the larger monomer retains the interaction with GP1B and the collagen, and also with the 2b3a platelet receptors. So in order to have adhesion and aggregation related to von Willebrand factor, you need all the multimers, while the factor VIII interaction can be present also in the dimer and the tetramer. Which are the functions of the von Willebrand factor? Differently from factor VIII, that is mainly a coagulation protein, the main function of von Willebrand factor is in vascular high shear stress, promotes platelet adhesion to the exposed subendothelium via collagen binding and the platelet GBMP receptor. Platelet and also platelet-protein interaction through the 2b3a. In these cartoons, you can find very easily that the fiber of collagen that are present in the subendothelium and the von Willebrand factor depicted in red here can interact when the subendothelium is exposed. And when the platelets goes very close to the von Willebrand factor and to the collagen, you see that the platelets can be bound to the GP1B receptor of the von Willebrand factor, to the one domain of the von Willebrand factor through the GP1B binding site, and also to the glycoprotein 2b3a. But we also know that von Willebrand factor is a carrier protein of the factor VIII procoagulant, because von Willebrand factor protects factor VIII from rapid proteolysis. Taking into consideration this function, a main important function of the von Willebrand factor, we can just summarize in these slides derived from a paper by Dr. Sadler the role of von Willebrand factor in hemostasis and thrombosis. You see that the level of von Willebrand factor in the normal population is in orange. It is between 150 to 150, 160 units per deciliter. So normal population has this kind of heterogeneous concentration of von Willebrand factor. But if you have a lower level or higher level, you can have the two sides of the coin. In other words, we have a bleeding, relatively high risk of bleeding when the level of von Willebrand factor goes to 0, and you have a high level of risk of thrombosis when the von Willebrand factor level into the circulation is higher than 250. And talking about von Willebrand disease, we have a very important, the diagnosis of von Willebrand disease inherited is very consistent with the defects of the von Willebrand factor gene by von Willebrand factor mutation when we have very low level, below 30. The area between 30 and 50 is a very, when we call low zone of von Willebrand factor levels, is very difficult to be diagnosed by von Willebrand factor molecular biology. Let's go now to the classification. The classification of von Willebrand factor is the most recent classification was published in 2006 when I was chairman of the von Willebrand factor subcommittee. And also for von Willebrand factor, we have all similar classification that we have in other deficiency of protein of blood coagulation. When we have a partial quantity deficiency of von Willebrand factor, this is functionally normal, we have type 1. When we have a qualitative von Willebrand factor defects, we have type 2. And according to the specific mutations, also to specific phenotype, when we have decreased von Willebrand factor dependent platelet adhesion and selective deficiency of high molecular weight multimers, we have type 2A. We have a type 2B when we have increased affinity for platelet glycoprotein 1B. We have a type 2M when decreased von Willebrand factor dependent platelet adhesion, but without a selective deficient of high molecular weight multimers. And we have a specific form of type 2N defined Normandy when there is a markedly decreased binding affinity for factor VIII, namely when we do have defects on the factor VIII von Willebrand factor binding site. Of course, differently from other, deficiency, we have also what we call the type 3, namely the virtually complete deficiency of von Willebrand factor, not only in the circulation, but also at the endothelia and the platelet sites. We move now to the guidelines for the clinical and laboratory investigation. That is the topic of our discussion today. One of the major problems we do have right now for von Willebrand disease patients is how to manage those patients who do have a level between, I would say, 25 to 50 of the von Willebrand factor activity. And so because von Willebrand factor is very difficult, in this case von Willebrand disease is very difficult to diagnose because most of these patients can show variable levels of von Willebrand factor to do several activities. And therefore, one of the major problems is to reduce misdiagnosis but avoid overdiagnosis because health insurance problems. So I'm sure that everybody knows that if you have a diagnosis of disease, health insurance problems is very important because the insurance can cost more money. Another aspect that we still have to deal with is the late diagnosis that can cause reduced VWD awareness. It's very important once we know that there is a patient with von Willebrand disease, everybody is ready to deal with bleeding problems. But if we don't know that there is a disease of von Willebrand factor or 4 von Willebrand factor levels, certainly these patients can be exposed to serious bleeding problems. More importantly, in terms of mild defect of type 1 von Willebrand is to consider the modified von Willebrand factor level. For instance, sex, females may exhibit greater variability due to estrogen values into the circulation. Age, von Willebrand factor is higher in older individuals. Pediatric case can be difficult sometimes to be diagnosed because von Willebrand factor can be modified by the difficulty of blood withdrawal. Hormones, as I said, estrogen can increase and thyroid hormone can modify level of von Willebrand factor. Exercise and stress can increase von Willebrand factor. Platelets and most importantly, blood group O show lower von Willebrand factor levels. Talking about the real issue of today, we know, what do we need to know right now? We know very well that the von Willebrand disease is considered the most common inherited bleeding disorder. And as we said, is due to quantitative or qualitative defects of von Willebrand factor. But we have very difficult definitions, very incomplete definition of the severe forms. So severe forms can be type 3 or type 1 or type 2N when factor VIII is also reduced. Another important aspect is, despite the complex and heterogeneous nature of the von Willebrand factor defects, nowadays all the von Willebrand disease types can be managed efficiently in most patients. So, which is the real problem we have to deal with? Correct diagnosis and classification, unfortunately, cannot be always available in several centers to provide the best therapeutic approach. Because differently from hemophilia A, easily classified severe, moderate, and mild by baseline factor VIII levels, VWD severity is not well defined within the types so far. So we know that there is type 3, we know that there is a type 2A, type 2B, type 2N, type 2M, type 1, but we don't know how severe the patients can show their bleeding phenotype. What do we need to know? Many things. The current challenges are listed here. I don't have time to discuss all of them. I will focus mainly today on the identification of patients at risk of bleeding and on the standardization of the von Willebrand factor test. All the other issues can be devoted for another, presentation. One important aspect we should always be aware of is that we don't have a disease without phenotype. So we don't have von Willebrand disease when we don't have bleeding history. So the three major criteria for correct diagnosis is bleeding history, low von Willebrand factor activity, and inheritance. And how we measure the bleeding phenotype. In 2006, the European group for von Willebrand disease published a paper showing that grading of each bleeding symptoms is really important to define bleeding phenotype of these patients. And if you can tell, the list of symptoms were graded by -1 to 4 according to the specific presentation. In other words, we have for VWD differently from hemophilia A, we have more mucocutaneous bleeding than I would say hemarthrosis and hematomas that are specific symptoms found in hemophilia. So if we check carefully the history of the bleeding symptoms in this patient, we can calculate a score that is very predictive, as I will show in the next slides, for bleeding symptoms, for bleeding phenotype of these patients. But this should be considered as a very important aspect for clinical diagnosis. What about the activities of von Willebrand factor to be used to classify, to identify von Willebrand? As I mentioned in the previous slides, the main adhesion activities are contained in A1, A3 domains. In A1 domain of von Willebrand factor, we have the interaction with platelet GP1B, and we have an assay that's called, historically called ristocytic factor. On the other side, we have a very important binding site on a 3 domain for the collagens of the subendothelial collagen N1. So if we use these assays, we certainly, together with the measurement of the antigen of von Willebrand factor, we are able to show enough patients. We are pretty sure to identify patients with von Willebrand disease. Another important is a positive family history. This is a pedigree of autosomal dominant inheritance, where the defect is found in the propositus, in the mother, and in the grandmother. And so you see that this is a typical, if we have this family, positive family history, we are sure that this is inherited von Willebrand disease. This is a flow chart that in Italy we have been using for making diagnosis. So I don't want to go specifically. The criteria is bleeding history, positive, level reduced, family history present. If you have a very low amount, we have a type 3. When we have a level measurable and ristocytic factor, but ristocytic factor and antigen are equal, we have type 1. When we have a discrepancy between the ristocytic factor and antigen below 0.6, and we have a loss of multimers, we have type 2A. When we do have this discrepancy between antigen, ristocytic factor activity and level, we have type 1. When we have enhanced interaction with the GP1B, we have 2B. And when we have defects of factor VIII binding, we have type 2N. Another important aspect we introduce in Italy is the DIVP test that can distinguish short F-life, responsive, not responsive patient with type 2, with type 1 von Willebrand disease. These are the spectral laboratory levels, a sort of summary of what we have been doing. So antigen, normal individual, type 1, type 2A, type 2B, type 1, 2N, and 3. Ristocytic factor is low, you see always low, absent in type 3. Factor VIII can be differently, RIPA can be increased, sometimes normal in type 2B. Platelet count can be reduced in type 2B, and the multimers, you see very well, the abnormality of the multimers are only type 2A and type 2B. And this is a very important aspect that this was published by our colleague in the United States. Let's move to the second part and final part of my talk, the review diagnosis. Sorry about that. I made a list of clinical laboratory diagnosis. So basic test, important, patient family history, bleeding score, and antigen, ristocytic factor, and collagen binding. And we have a special test, RIPA test, von Willebrand factor VIII binding, multimeric analysis. Of course, molecular genetics can be important, but usually molecular genetics is useful to confirm diagnosis of inherited von Willebrand disease within the same family. How do we measure now the von Willebrand factor antigen? We have immunoassay that measure the concentration of von Willebrand factor protein in plasma, actual protein responsible for binding to factor VIII and GPB9 complex, we know very well. But we have now availability over, we detect all forms of von Willebrand factor. We cannot discriminate between multimeric size. This is an important aspect to discuss. And we have these very quick and reliable assay called the latex immunoacid-based testing. You see the patient's the patient plasma goes to the testing well, reagent beads coated with anti-von Willebrand factor, and then we incubate, and then the instrument reading change in optical density secondary to aggregation. So it's very simple and it's very quick and reliable. This is the rhesus-CT cofactor platelet aggregometric method. This was the original method. So you have the tube with the stirrer. We have the rhesus-CT in the inducer, and the light goes through this tube, transparent tubes. And when there are aggregates, you see there is the transmittance gives the curves is higher when you have a higher concentration of von Willebrand factor. So we have to use normal fixed platelets, patient plasma dilution, rhesus-CT in standard concentration. Which are the parameters that can influence rhesus-CT cofactor? The antigen, the multimeric pattern, so we have abnormality type 2A, type 2B, and the mutation on the one domain in type 2M. So this is I would say, what we consider in the past the gold standard. But this assay is not, the coefficient of variation is very high, the sensitivity is very low. Why do we are going? This is the most recent automatic method for rhesus-CT cofactor, and it can be done by immunoturbimetric and chemiluminescence systems. This is the Hemosil rhesus-CT cofactor assay, the Hemosil Acustar rhesus-CT cofactor assay. The figures are these are the latex particles, the monoclonal antibodies. Well, let's start with the reaction on the immunoturbimetric assay. Latex particle coated with a recombinant fragment of platelet GP1B through a monoclonal antibody, which binds von Willebrand factor in the presence of rhesus-CT and results in agglutination. So measuring this agglutination, we have the activity of von Willebrand factor. On the other side, the chemiluminescence, we have a magnetic particle coated with a recombinant fragment of platelet GP1B through a monoclonal antibody, which binds von Willebrand factor in the presence of rhesus-CT. Binding of isoluminol labeled anti-von Willebrand factor antibody, and the addition of two catalysts to produce a chemiluminescent reaction. So these systems are very well standardized, and they are very good for general, diagnosis of von Willebrand factor. Why we believe so? Because if we put it together and we compare the Hemosil rhesus-CT cofactor, Hemosil Acustar rhesus-CT cofactor versus what we called in the past the platelet aggregometric von Willebrand factor rhesus-CT cofactor, let's say the gold standard, you see that the curves, the sample size is very high, the slope is very good, and the correlation is very good also. But compared to the original platelet aggregometric assay, these Hemosil rhesus-CT cofactor, Hemosil Acustar rhesus-CT cofactor have better, sensitivity, because they can go down to very close to 3-5%, differently from the original test. And this is the explanations of a new antibody, Hemosil von Willebrand factor activity assays with antibody anti-von Willebrand factor in one domain, plasma von Willebrand factor, no rhesus-CT need, because there is a modification of the antibody, because it can recognize von Willebrand factor without rhesus-CT. And so this is more important, because you have the same evaluation and very important sensitivity and reproducibility by using this test. And also, we have several papers showing the validation of the panel automatic immunohistochemistry assay antigen activity in the screening of von Willebrand disease. So it's very well known and applicable in many laboratories. And this is another recent, last year, two-center comparative evaluation of new automatic assay for Willebrand factor, histiocytic cofactor activity, and antigen. I cannot go into detail, but if you check all the data here, ELISA and LCL for the antigen, AcuStar and top, they show very well result of reproducibility. What about the collagen binding? Additional activity test, because it evaluates von Willebrand factor capability to bind the collagen. It mimics von Willebrand factor interaction with the subendothelium collagen matrix at site of vascular injury. It is dependent on von Willebrand factor multimeric size because collagen binds more readily with the high molecular weight multimers. Studies show that von Willebrand factor collagen can serve as a surrogate measure for the presence of high molecular weight multimers. When tested with von Willebrand factor and rhesus, it can improve differentiation between type 1, type 2A, type 2B, and type 2M. And these are the papers that we published and several groups have published in the recent years. So, what about the collagen? You see the ELISA plates. This is a publication we published in 2004. You put the collagen in the well. Then you add the plasma, and then diluted plasma. Then we add the anti-von Willebrand factor, anti-von Willebrand factor HPR conjugated polyclonal antibodies. And the collagen in this test was type 1, 95%, the 5, type 3 collagen. And the parameter that influenced this assay are multimeric pattern and the mutation of the A1 and A3 domain. So, useful if we can put the new histiocytic cofactor-like assays together with the collagen, we're pretty sure to identify 95% of the patients with von Willebrand disease. What about the multimers? Multimers are important. This is a slide originally produced by Professor Bute in Hamburg. You see very well that if you have a normal subject, we have type 1B or it's very important specifically for the type 2, type 2A, type 2B, type 2C, type 2D, and subtype type 2E. You see that if you increase the concentration of the agarose, you see also the binding that's completely different from normal control. So this is another important test to specifically evaluate the von Willebrand factor types. But in terms of bleeding phenotype, probably this is important only when you have a lot of loss of high molecular weight multimers. Last but not least is the binding assay to ELISA using von Willebrand factor immobilized and measuring the bound factor rate. In this system, you put von Willebrand factor immobilized, that you have the plasma, then you add recombinant factor 8C, and you see how the factor 8C can be bound to the von Willebrand factor immobilized from the patients. And you see that there is homozygous, when you have homozygous defect of the type 2N, you have a very loss of course, of activity when you have normal, and when you have heterozygous, you have something intermediate. So this is another specific assay that should be considered. We're moving now to the very last part of my talk. So what we need to know in order to improve the management of von Willebrand disease. Which are the minimal requirements for patient management? I would like to summarize what we have been discussing in the previous slides. So different from hemophilia A, several laboratory tests must be always performed for diagnosis in order to provide the appropriate therapy to patients with different VWD types. However, bleeding phenotype is also related to the levels of the von Willebrand factor activity measured by histiocytic cofactor von Willebrand factor collagen binding. So, in other words, if we consider that the core part of the von Willebrand factor that is contained in A1 and the 3 domains, and if we have a histiocytic cofactor and the von Willebrand factor collagen binding, as the activity assay for measuring these portion of the molecule. This is very important for the interaction with the platelets of endothelium. These should be considered the assay that are important for classifying patient's phenotype. And manual method, we know very well, as we mentioned briefly before. Manual method for risk-specific cofactor conjugate available at local laboratories are not always standardized and can show high variability, coefficient of variation more than 15, and poor reproducibility. We have now a very important novel automatic test for von Willebrand factor activities assessed at the same time as von Willebrand factor antigen that may offer the most reliable approach to identify patients with mild, moderate, and severe forms of VWD. Lab data of this automatic assay together with the bleeding score at the DLP trial diagnosis can predict clinical outcomes. Why do we believe so? Because in the recent publication from a very large prospective cohort study in Italian cases, we found that the bleeding score together with the von Willebrand factor activity levels are important to predict clinical outcomes as replacement therapy in adults von Willebrand disease patients. And high bleeding score correlates with intensive or demand therapy and may identify cases with kind of regular prophylaxis. The most important message of the paper is contained in this slide: incidence of mucosal and non-mucosal bleeding in 796 patients. Look at the bleeding score. When we have a bleeding score measured by the grading system that we described before, when we have less than 5, like in normal, we have a very, very low incidence of bleeding. When we have a 5 to 10, we have some increased incidence of bleeding, rate of bleeding. But when we have more than 10 in the history, especially in adults, the incidence of rate of bleeding is very high. And this goes very well with the risk-specific cofactor activity. And if we put together a risk-specific cofactor versus bleeding score, the two parameters are, inversely correlated. So the lower is the risk-specific cofactor level activity measured with the new systems, for instance, is the higher is the bleeding score. So by putting together bleeding score and levels of activity, we certainly come up with some important information on the bleeding phenotype. Last few slides, discussion and conclusion. So the von Willebrand factor molecule has multifunctional roles. Therefore, lab diagnosis for inherited VWD requires more than one laboratory test in conjunction with the clinical criteria. The clinical criteria is bleeding history, inheritance pattern, other factors, but the von Willebrand factor activity measured by risk-specific cofactor collagen binding. We have antigen effect rate for type 1 and type 3. Additional tests required for confirmation of type 2N and type 2B, together with multiples with type 2A, type 2N. But certainly, novel automatic assay now commercially available can help. Why they can help? Because reduce errors due to manual handling of reagents. They can shorter time to treatment. They can reduce costly send-outs, because all the laboratory lab, including routine lab, can perform these assays. And I will finish here, and I will be happy to answer to any questions you might ask me. Thank you for your attention.
At this time, we would like to take any questions you may have for our presenter. To ask a question, please use the Q&A option in the floating toolbar at the top of your screen. Simply type your question in the open area and click Send to submit. Please hold as we compile the Q&A roster. Please continue to submit your questions via the Q&A option found in the floating toolbar at the top of your screen. We will continue to hold as we compile the Q&A roster. Thank you very much for your questions so far. Please continue to submit your questions via the Q&A option found in the floating toolbar at the top of your screen. We will continue to hold as we compile the Q&A roster. Please continue to submit your questions via the Q&A option found in the floating toolbar at the top of your screen. We will continue to hold as we compile the Q&A roster. At this time, we would like to begin the Q&A session. I would now like to introduce Dr. Giulio Semprini from Instrumentation Laboratory to facilitate the Q&A portion of the presentation. Dr. Semprini, you may begin.
Thank you, Celso. So, Professor Federici, thank you for the presentation. Let's start with the questions for you. So, can you elaborate on the use of Willebrand collagen binding and the Willebrand collagen binding antigen ratio in conjunction with the other tests such as antigen and RECOV to differentiate subtypes of Willebrand disease, and if you're using it at the same time, and RECOV and antigen, or as a reflex? Let me just try to repeat the question so everybody can understand. Can you elaborate on the use of Willebrand collagen binding and Willebrand collagen binding antigen ratio in conjunction with the other tests, antigen, RECOV, to differentiate subtypes of Willebrand disease, and if you are using it at the same time as a RECOV and antigen, or as a reflex? Please, Professor Federici, thank you.
Good afternoon and good morning, all of you. This is the first question. It's a very important question. I think that in my presentation it was really clear that the collagen binding explore different activities of a Willebrand factor compared to the risk-specific factor. In other words, collagen binding is more, it's useful to understand what's going on with the subendothelial of Willebrand activity, and risk-specific factor is useful to assess the Willebrand factor interaction with the platelet glycoprotein 1b. So if we think about the principles, I think it's really important to have both assays in the system. And I think that you can explore, for instance, that there is certainly important to understand if there is a loss of activity in both sites, erythrocytin and collagen binding, compared to the concentration of the protein measured by von Willebrand factor antigen. In the past, we have been using for many years both assays to understand, for instance, the difference between von Willebrand disease type 2A versus type 2M. In other words, usually in the type 2A and type 2B, the collagen binding activity versus antigen is lower than, for instance, in the case of von Willebrand disease type 2M. So, summarizing my answer, I think that both assays should be useful for setting up the classification of the different forms of von Willebrand disease together with the ratio of antigen.
Okay, thank you, Professor Federici. We have another question for you. What are the challenges involved in providing a correct diagnosis of Willebrand disease? So, what are the challenges involved in providing a correct diagnosis for Willebrand disease?
The challenges are related to the major clinical aspects of von Willebrand disease. If we can have a very good apparatus to set up very quickly correct diagnosis of von Willebrand disease, we can also immediately organize the appropriate treatments. For instance, if we have with a very simple laboratory assay, we have a very we are happy, we have the possibility to know very soon the diagnostic of von Willebrand disease patients. We know how to approach these patients with the therapy, namely the DAVP of von Willebrand factor concentrates. In other words, if we can have a rapid diagnostic of patients with type 1 versus type 2A versus type 2B or type 2M, we also can correlate this disorder to the phenotype, the bleeding phenotype of this patient. So, bleeding history, as I said, and von Willebrand factor diagnostic lab diagnosis should be performed together. And by using both bleeding history and the evaluation of the activity of von Willebrand factor in this patient, we can understand the outcomes of these patients.
Okay, thank you. Let's go on again talking about the patient diagnosis. And the question is, how will the implementation of standardized automated Willebrand testing affect patient diagnosis and outcome? So, how will the implementation of standardized automated Willebrand testing affect patient diagnosis and outcome?
So we should consider that, thank you for this question because it's really relevant to what we have been doing for the last 10 years. In our experience, one of the major problems we have been facing for the last 10 years is that many laboratories at the general hospital have still problems for understanding the diagnostic of von Willebrand disease. So by having a standardized system like that we are proposing, is important because not only specialized center can have a correct diagnosis, but also general lab assisting the general hematologist taking care of the von Willebrand disease patients. So the other important aspect is that originally these traditional assays for von Willebrand activity should be performed and sometimes do not have a coefficient of variation very good. With these novel assay, the sensitivity and the coefficient of variation is very good, and there is easy to understand this kind of assay can be performed very simply by general technicians and by general operators in the lab. Thank you.
Okay, thank you. Let's change a little bit now. In developing countries, what would be your recommendation to promote the Willebrand disease awareness and implement Willebrand disease testing within their institutions? So leaving Europe for a second and US, in developing countries, what would be your recommendation to promote Willebrand disease awareness and implement Willebrand disease testing within their institutions?
This is very important. I've been working in collaboration with the World Federation of Hemophilia in many developing countries, and I visited several of these developing countries. And I tried to explain them that von Willebrand disease diagnosis is difficult, but nowadays the diagnostic should be available in also these developing countries, because they have patients with many patients with von Willebrand disease, especially in the Muslim countries where consanguineous marriages are frequent because of the inheritance pattern of von Willebrand disease. So my suggestion for them is just to make sure that just to collect a very detailed bleeding history by the patient, from the patient is really important. They should have a very simple test in their lab for activity like those we are talking about, erythrocytic cofactor and collagen binding, together with the antigen. And by using these three simple assays, and they can just perform in their way with some support of money, they can just have the answer for the correct diagnostic and the correct therapeutic approach.
Thank you. It seems the topic is very interesting. We have several questions again. Let's proceed. How will genetic testing affect the diagnosis of Willebrand disease? So how will genetic testing affect the diagnosis of Willebrand disease?
This is not an important question. So, of course, the genetic test can be performed in von Willebrand disease patients, but they are very expensive and they are very time-consuming because of the large extension of the von Willebrand factor gene. So we are dealing with 52 exons and 51 introns, so we have to check these mutations. What is really interesting for the patient care? Certainly, we don't want we have a very simple, in several patients with type 2B, for instance, or type 2N, we have a specific locations of the von Willebrand factor gene where the mutation can be found very easily. So that can be found. In case we would like to confirm our suspect of type 2B or type 2N. The same can be applied in some way in the type 2A and type 2M. But in terms of outcomes of these patients, knowing the exact mutation is not necessary to approach the patients with the correct therapeutic approach. So the phenotype is sufficient to organize and to understand the specific type and to organize for this specific type the specific therapeutic approach. One word should be spent for patients with severe forms like type 3. In those patients with type 3, sometimes we have to be aware of the possibility that those patients, because of the complete probably the complete lack of von Willebrand factor gene, they can recognize as exogenous any von Willebrand factor introduced in their body by transfusion of von Willebrand factor concentrate. So in those patients, there will be a possibility, very remote, but sometimes can be, of the development of antibody against von Willebrand factor. Those patients are at very risk for having anaphylactic reaction. So we should, in these patients, the molecular diagnosis can be done. The other possibility is that if you have a family a mother who already generated a patient with von Willebrand disease stage 3, if she becomes pregnant another time, she should know whether the next newborn is affected or not affected with WD83. And this can be done by using prenatal diagnosis.
Okay, thank you. So, can you comment on the role of the Willebrand factor propeptide and its clinical utility in the diagnosis of the Willebrand disease? Can you comment on the role of the Willebrand factor propeptide and its clinical utility in the diagnosis of the Willebrand disease?
So the propeptide is the part of the protein that's cleaved from the von Willebrand factor when von Willebrand factor goes outside of endothelial cell. And so it has been, proposed as a very good way of understanding whether or not there will be an abnormality of the von Willebrand factor gene that produces a protein that is keen to be removed from the circulation in a very short time. So having the propeptide can help to understand, for instance, whether or not the effect of the DAVP can be short-lasting. Of course, this is an important question, and the propeptide can be important in this way. And for instance, propeptide versus von Willebrand factor antigen is always high in those patients with increased clearance of von Willebrand factor. So we have an additional demonstration what is going to happen when the patient release from abnormal von Willebrand factor from her endothelial cell. Of course, this is important, but we can have indirect information about this by using the DAVP trial. If we see that after the DAVP, the patients have a short clearance of the von Willebrand factor, of course, if they have at least enough amount of von Willebrand factor inside the endothelial cell, we can also have the same information by using this system. But, of course, propeptide is another tool that can be useful.
Thank you very much. Time is running very fast, but we still have a couple of minutes for questions and answers, so let's proceed again. What role does collagen 4 and collagen 6 play in evaluating the collagen binding activity of Willebrand factor? So we're asking you about the collagen 4 and collagen 6 roles in evaluating the CBA on factor Willebrand.
This is another important question. The von Willebrand factor is a complex glycoprotein, and von Willebrand factor has many interactions with its different binding sites. So we know very well that, for instance, A1 domain can, besides interacting with the G1B receptor or platelets, can also interact with the collagen type 6 and type 4. So having this additional collagen around can be important because we can understand whether or not there are patients with the specific mutations responsible for abnormality of this binding site with the collagen in a different way that is usually assessed by using the other two type of collagen, type 1 and type 3, that are more keen to more available for understanding the interaction between von Willebrand factor A1, A3 domain and with these type of collagen. So if we have a patient, probably the most important thing, if we have a patient with a bleeding history, von Willebrand factor level relatively normal, and we don't understand why, when we exclude any other platelet interactions, why this bleeding occur, certainly we can also explore the possibility to evaluate the von Willebrand factor interaction with collagen type 4 and 6.
Okay, thank you. Since we are talking about collagen, types of collagen, we have also another question that says, is it necessary to perform specific ELISA testing for type 1 and type 3 collagen?
In the past, if we consider general papers about role of collagen in diagnosis of von Willebrand disease, most of the data of abnormal collagen are consistent with the abnormality of rhesus factor. So, in other words, in most of the patients, I would say 98% of the patients, the collagen binding is abnormal when rhesus factor is abnormal. However, there are very few cases where there are families genetically related, of course, where the collagen binding is affected, is abnormal, and rhesus factor is normal. So this is another possibility, another tool that we have to explore. So if we can just have the collagen binding and some family-related bleeding disorder, we should give the possibility to have a chance to measure the collagen binding, even the antigen and rhesus factor is normal.
Okay, we are very, very close to the end, and we have several questions again in the queue. So I think we can anticipate everybody that all the questions will be then answered maybe in the next weeks, and we will provide the answer somehow, somewhere, somewhen. But I think that question is important for the moment. We haven't talked about so much about the ADAMTS13, and I think that the relation between ADAMTS13 and Willebrand factor are very, very important. So if you don't mind, if you would like to elaborate a little bit about it.
So ADAMTS13 is the specific enzyme that cleaves von Willebrand factor physiologically, and of course, when we have ADAMTS13 system available and with a very simple assay, it would be very useful to understand what's going on with the patients with the bleeding disorder. So far, until now, we have not found patients with specific mutations located at the binding site of ADAMTS13. But you can never tell. We can have this possibility in the future, so we don't know. In other words, since the von Willebrand factor is the real substrate, and the ADAMTS13, its physiological enzymes, knowing and having the possibility to measure ADAMTS13 together with the von Willebrand factor activity will be certainly useful to understand if there are strange cases. Of course, we know very well that ADAMTS13 is deficiency of ADAMTS13 activities are more related to thrombotic events than on bleeding events. So that's why we certainly would propose ADAMTS13 activity versus rhesus factor or von Willebrand factor activity like collagen, for instance, to measure any risk for thrombosis. But as far as we know, since there is a possibility that abnormalities of the von Willebrand factor gene can be also related to the cleavage site, to the sites where the ADAMTS13 can interact, we certainly we are very happy. We would like to be certainly happy. We are certainly happy to have the possibility to measure also ADAMTS13 activity in this setting of assay.
Okay, thank you very much, Professor Federici. Time is really running fast, and you are a great speaker. We should go on for hours in listening to your answers, but I think it's time to close the meeting, so I'm just giving back to Celso the connection. Celso, can you close the meeting now?
Yes, thank you, Giulio. And thank you to all our participants for joining us today. As you leave the webinar, you'll be prompted to complete a short survey. Please complete this survey as your feedback is truly appreciated. This does conclude our web conference, and you may now disconnect.